Alrighty, good afternoon, everyone. Why don't we go ahead and get started? As usual, please chat in your full name, your email, and where you're tuning in from if you'd like to receive CME credit. And today, since we are having a Q&A session, please chat in any questions you'd like addressed as well here in the chat feature. So before we jump into any of the cues that we have submitted for the session, Dr. Hodder, I wanted to turn things to you for any comments that you wanted to say.
No, I just want to welcome everybody. We've been doing this for months and months, and I think we're likely to continue to. And today we just thought, because some sessions we've not had much time to just chat and get questions, we thought we would do that. But I would urge you to please contact Mitra if there are specific subject areas relevant to COVID-19 that you would like to cover. We would be happy to find experts and to do that. So I think, you know, I don't know, I see Dr. Costello's on. Lisa, do you have any comments?
Nope, other than I'm working on us at our regional site. If the baby comes in that I have to run to, I apologize. That's where I'll be going. But otherwise, looking forward to hearing everyone's questions and chiming in where I can.
I will say, thank you. I will say that, you know, every morning we have a team that really has a report with the transmissibility, the R instantaneous, and the 7-day rolling average. And if you look overall across West Virginia, you know, the cases and the incidence continues to go up. I would say Mon County has done very well, and in recent weeks or two, it has come down. But I think that, you know, consistent with many areas in the Midwest, it is really heating up at a time when the temperature outside is cooling down. People are going to be inside. So this isn't sort of a very upbeat way to start, but I think the next couple of months are likely to see a lot of disease activity and be very tough.
And I would just chime into that. We're also seeing increased hospitalizations, which I think when we always talk about this, not only people getting sick, but then you know, how much stress that puts on the healthcare system. I don't think they're all COVID-19 admissions, but you add that on top of other seasons that we're entering into during this time of year. I do believe that that is certainly something on the radar of many individuals as we've gone back to elective procedures and things that were put off when we complete shutdown. I think that overall we're seeing our hospital systems also be busy in this state.
And I don't know if there are any, I can't see sort of everybody that's on, but is there anyone else that would like to just make some comments before we start with a few questions? Hearing none, Mitra, maybe do you have a couple of questions that have been holdovers?
Yes, absolutely. So we'll just jump right in. So the first question we got submitted was, are there any newly published information or guidance on neurological symptoms identified post-COVID infection?
Yeah, that's a good question. There is Nature Reviews in Neurology has a recently published overview, not just of long COVID neurologic symptoms, but of neurologic involvement throughout COVID. And they actually have sort of a nice paradigm. They talk about sort of an acute infection where obviously, you know, cytokine storm, hypoxia, you know, vasculitis may all feed into neurologic symptoms. They separate that out from a, you know, directly neuroinvasive. We know that the SARS-CoV-1 back in the early part of this, you know, it was 2002, 2003 or so in Hong Kong, has been demonstrated to directly invade, and there are ACE2 receptors in the CNS. And, you know, there is, though the studies, some have claimed to see that, this review suggests that we probably haven't absolutely documented it, but it's highly probable. And obviously there can be neuromanifestations there. And then relevant to chronic neurologic manifestations after COVID, that is really thought to be more of an immune-mediated complication. And certainly there have been cases of demyelination, Guillain-Barré, and so forth. And actually that led to some of the real concern about the vaccine trial that is still on hold in the US, that actually had a case of transverse myelitis, which is demyelination, and that vaccine had been associated with a neurologic case that was later defined as multiple sclerosis, which obviously is a demyelinating disease as well. But there are other manifestations, and then there are the what's believed to be the neurologic or the psychiatric manifestations. There have certainly been cases of reported new onset of depression, and more commonly a chronic fatigue syndrome, or what has been called brain fog. Maybe Lisa has, I have not seen good studies that have really defined those and looked at really what the prevalence of those is going to be, but there are a number of reports, so I think it's not going to be uncommon. And for specific guidelines on management, I have not seen as of yet evidence-based guidelines. I don't know, Lisa, do you have more to add to that?
I don't have much more to add. From a pediatric standpoint, there's a lot gets COVID, but all the alternative learning mechanisms that we're seeing and the increased screen time and the lack of social development or skills that one would typically see in person. I think that time's going to tell the long-term development and skill that we see in our youngest children who would typically be in an in-person setting. And that's something that's being monitored kind of because it has approached it differently. So I think it just goes along with the lines of the obviously the depression from actually getting SARS-CoV-2, but then also we're seeing increased anxiety and depression across the board because of the interventions needed to address SARS-CoV-2. So it's been more and more reported about increased substance use disorder, increased overdoses, as well as increased admissions for suicide attempts, particularly in the pediatric population.
And going back to really just address the chronic neurologic complications, that is not just specific to SARS-CoV-2. It's clearly been described for decades and decades with influenza and with other viruses. So it's not a big surprise that we're seeing these, but obviously with the pandemic and, sort of surge in infections, it's really brought it to the forefront.
Thank you to both Dr. Hodder and Dr. Costello for that.
Yeah, Mitra, we should make available that Nature reviews in neurology that I mentioned. If I can actually send it to you.
Absolutely, that'll be perfect. I'll attach it in the recap email for sure. Thank you. So we got 2 questions in through the chat. The first one was, how scary is the case of a Dutch woman contracting the second round of COVID-19 that led to her death?
Well, anything that you contract that leads to death is scary, but I think, though there have been a couple of what I think are clearly documented reinfections, I think at this point it's uncommon, this close to the primary infection. So that's number one. Again, we have seen this actually with influenza. You saw it in the 1918 epidemic. And there were clearly documented cases of people getting infected soon after, as clearly documented as it could be from 1918 and 1919. But I think it was pretty clear. So the bottom line is, and I don't know the specifics about the Dutch case, but there was a Hong Kong case, and there has been a case in this country. So my read on this is it can happen. It's very uncommon. Why it happens, to my read, is not clear. I think we're going to have to sort of define that. But I think that everybody needs to take precautions. You can't say, oh, I got COVID and I can quit wearing the mask and quit washing my hands. That would not be the case. Nonetheless, that we're going into flu season, and flu influenza is deadly as well. I know, Lisa.
Yeah, this is something the CDC has been monitoring. It was back in July because we had a couple cases in West Virginia that we were concerned that could have been reinfections. When the samples of the cases in West Virginia were sent to the CDC, it was found that they were not reinfections. It was just detection of the ongoing virus in the study. But this is something that they've continued, and we've seen, as Dr. Hodder mentioned, with other coronaviruses, that potential to have reinfection. So the thought always existed that would be the case with SARS-CoV-2. Now there's starting to be more reports, that we're seeing of that actually happening as the pandemic progresses. But I do know, and this is for the providers out there, if you have a case in which you feel that could be the case, that it would be a potential reinfection, the state works very closely with the CDC to get those samples sent so that it can be analyzed to determine if this is true reinfection, or are we just simply still detecting viral particles in this, when they're being tested.
Thank you both very much. Samantha chatted in saying that the governor's color coding chart is very confusing, and that she's been referring to the Harvard model more and more. So her question was, what do you think is the best data and best source for data to chart the current COVID status in our state and counties?
Lisa, do you want to take that one, working with DHHR?
Sure, I will try. I think it's a good question. Clay Marsh, our coronavirus czar, many at W also know him well because he's also our vice president. He wrote a article working to explain that. I think individuals have found it confusing as it's been changed over time. The rationale for the adaptations has been, the Harvard model was more so designed with an urban population, and ours were, the initial map was identified, based upon that, or working closely with that, and then over time finding how it is impacted in rural communities and the adaptations for that. So I usually look at a model of both. I mean, I think throughout this entire pandemic, the University of Washington model, I've looked at multiple different models, including the Harvard color-coded map. And I think that as we continue to learn more, you'll see areas progressing. The RT, which Dr. Hodder spoke of, is another factor that I kind of look at and take that all into collaborate, I guess I look at all of those and then make the interpretation to get a better idea, because it's been a balance, because people have wanted more data on the dashboard, but then we put more data, and then I think that just drives more confusion. So it's a matter of trying to identify what is a good balance to strike. So for me, I think looking at a combination of those in conjunction with your local health department to determine what is, really what are we seeing in those communities. And then Dr. Rexroad is on here, not to call her out, but she lives in a bordering county. And I think one of the challenges that we have particularly had is, what is the spread in counties outside of ours, or bordering counties? And we've had a continually hard time trying to assess. So I do think the Harvard map may help in that, of getting an idea of what are we seeing in other counties, because West Virginia is such a bordering state just by our nature. And so sometimes that can be, I think, a challenge too. We have a resident of our community who's tested in another community, and then it's hard to get those results as we see more commercial pharmacies come on board and more of these commercial type testing. And then, obviously, if there's a future self-home administered test, that's even going to create more challenges, because it's then truly hard to determine, to get those test results back. So they're all models for, projection based upon data that we receive. And so those are what I use. So obviously the DHHR map, and then in combination with the Harvard map, looking at the RT value. Not sure if I'll let you add on to anything as well.
Well, I just want to say, so I actually talked to the Harvard guys, because when that first came out on July 1st, I actually kind of liked it. But you gotta understand a couple of things. Number one, the Harvard model goes to 3 different websites and pulls numbers off. Those numbers, largely come from the, West Virginia website. It's posted publicly. According to what they told me, and I talked to them, I don't know, maybe the end of July, beginning of August, they then send that to, I think they said Microsoft, which, sort of adjudicates which of those 3 sources, what the numbers are. And then they put them out there. And those categories, I said, how did you get green, yellow, orange, red? And they said, well, that was expert opinion. It wasn't modeled. It was just expert opinion. And as Lisa said, most of those, not all, but a lot of that was based on urban experience, because obviously COVID surges in rural areas came somewhat later. So you gotta bear that in mind. And I would suggest everybody's building this airplane in the air. I have not been, and we're working right now to predict based on RT and does incidence make a difference, sort of a near-term increase. I think the long-term models, and I could say this almost universally, have been lousy. And I think that really, to say that you can predict long-term is not clear. I think near-term is pretty good. And I do think, in general, if you look, and Harvard isn't the only one, there's an urban observatory, everybody has a map, but I think, broad trends are consistent across them. Where you sort of cut the color coding and so forth, I think is difficult to know. And I'm not sure anybody has, sort of an answer at this point that is really, I mean, look, this is a new epidemic. We've only been gone a couple months. Now we got, schools opening up. So I think it's not clear, but that's my personal take. And I was shocked. I really, when I talked to the Harvard guys, I really thought they had probably modeled this. And actually, they hadn't. It was all expert opinion.
Yeah, and I think I would just chime in that, we went, the color coding system, there was a lot of discussions about, I think it was done to try to model, like, when you think of a traffic light, but we have seen some detriment in people when a county is green, they're like, oh, we can have free for all. I mean, and then you don't have to wear your masks or this or that. And I think that, the message should be and continue that, okay, if our case count is low, let's keep it that way by continuing the public health recommendations. But unfortunately, we've seen an indication of decreased case count lead to people making their, going back to having more gatherings, maybe not being as compliant with their mask wearing. And then that is what I think creates almost a false sense of security, that you can go about however you would choose. But, at the end of the day, we still have a pandemic going on. And there's always going to be a little bit of lag. I mean, this data, the way that it's acquired, testing time turnaround is getting better, but it still sometimes takes a few days. The data has to be researched. There's times where there could be duplicate data. And so I've had many discussions with individuals who have cut, to the case to case that have been reported on our own DHHR website. And there, why is there variations? Well, there's variations because the data gets looked at and interpreted, and then it gets corrected based upon what we find through in case investigation. As we see an increase in cases, unfortunately, those case investigations, that's a more strain on the local health department. It takes longer time, to be able to really correct that data or make adjustments based upon what we're learning through the case investigation. So I think whatever model you're using, whatever map you're looking at, the message should still be the same regardless. If you're seeing low evidence of spread or higher cases, we definitely still need to be following these public health recommendations, because certainly we've seen it more and more when there's been a decreased case number, then people think, oh, well, it's fine, I don't have to wear my mask anymore, we can have gatherings, et cetera, et cetera. But, and then unfortunately, we then many times see spread as a result of that.
This is Samantha. Just as a follow-up to my question there, of course, I'm a psychologist and I'm seeing a lot of very anxious patients. Since there are so many unknowns still, and tracking this data can be difficult, and we're still new to everything, what do you say to patients to help them feel more empowered or to help them with that anxiety?
Well, I would say this is not voodoo. This is a virus. And we know how this virus is transmitted. And we know what to do to prevent transmission of this virus. So, I mean, I'm not a psychologist or a psychiatrist, but when I feel I have more control, I'm much happier. And when you're proactive, and I think, really behavior is what we have. So, I wouldn't be nervous, but I would just do all the stuff that we've said a million times. Wear a mask, whenever you're in public or around other people that aren't the folks that you're just living with. Wash your hands frequently. Leave your hands. Do not be touching your eyes and your mouth and your nose. Wipe things off frequently. Avoid large gatherings. Actually, there have been a number of recent cases of small outbreaks with family gatherings. And I think, Thanksgiving is just around the corner. If folks are coming, you have an extended family and they're coming from different parts of the country, that's a high risk situation. So, if you're nervous and so forth, maybe good to have Zoom Thanksgiving. I mean, everybody sort of has to judge about what makes them comfortable. So I do think that the message that I say to people is, we can get control of this. It is in our purview to control it, because it's all about behavior right now, until such time as we get, good drugs that prevent it and a vaccine. I don't know, that's my personal opinion. I don't know, Lisa or others.
I agree wholeheartedly. The only thing I would add is maybe where they're getting information from, because I think that we're seeing a lot of fear and anxiety associated with, there's so much stuff on the internet. I mean, we see this in children on social media, there can be bullying. So I do think if someone is really anxious about this, this is what we talk about in children, limit their media consumption and direct them to reputable sources like the CDC, or to reputable sources, so they're not just hearing, someone's opinion that's not really based upon any evidence that we have. Because I think that that we know that happens in other situations, and I've seen it a lot here in the pandemic, because there is a lot of different information. And so I think sometimes talking to them about how much information they're consuming, and just making sure that they stick to reputable sites may aid. But I agree with everything Dr. Hodder said, but that's the only other piece that I would add in, because that is something that we recommend, particularly in children. But I honestly think probably across the board, it probably could be helpful to, for some individuals, limit their media consumptions, because the only thing that gets reported are deaths and, doom and gloom. And so it can be challenging to process all of that, and I think be overwhelming for individuals.
Thank you both very much. And thank you, Samantha, for your follow-up question. So Carl chatted in a question asking if you could please address the current state of testing in West Virginia, especially rapid testing and those other in-lab PCR.
Lisa, do you want to take that one first?
Sure. So it's a really good question. I was going to bring up, and we can share, there was a health alert sent out last week by Dr. Ayn Amjad in regards to testing. The state has brought on many other lab partners in regards to labs that are able to run the PCR test. we see more and more hospitals developing their own in-house systems to be able to process PCR. And by and large, the PCR remains, I think, the most commonly used testing modality that we have, and still to date the most trusted testing option we have. The rapid antigen testing is coming more on board because the Centers for Medicaid and Medicare, CMS, nationally made it a point to provide rapid tests to all long-term care facilities. So many of our nursing home facilities in the state have received antigen testing. I know that many private practices have also received antigen testing. I think that the challenge is what is the role of antigen testing? I have seen, really it's better used in symptomatic individuals, and even variety amongst the types of antigen testing as to what is more, what we've seen more valid than not, and other types even across the antigen. So in regards to what settings they're applied, I do think we're seeing more antigen testing be used for surveillance at times in regards to these congregate care settings. And if there is a positive, then working to have confirmation with a PCR before perhaps an outbreak designation would be made, so that can be confirmed. But given the rapidity, or the rapid nature of the antigen testing, it at least can help trigger a further evaluation in those congregate care settings. At least in our state, half of our deaths have been from a congregate care setting. So that is something that's certainly been on our radar in West Virginia. So I will find the HAN and share it that has the more specifics, and hopefully many of you, it just went out, I think, at the end of last week. But the state as a whole continues to work to expand testing. I'm sure many of you may have seen in the governor, now that any county that triggers orange, he wants, daily testing opportunities so that we can increase testing in the communities to have better access. I personally think the challenge with testing has been the local health department testing opportunities that we have are, open to everyone. They're free. You can just show up. You don't need to have an order. Where I've seen a lot of struggle is many other hospital systems that are offering testing still require a lab order. I had a friend reach out, basically ask me how they could get their loved one tested. And I mean, it took me literally half a morning to get this person an order to go get a test. I mean, I think 9 months into the pandemic, that's an issue. And I think then further deters testing. So I think that continues to be an ongoing challenge in regards to some places still requiring an order versus just drive up testing that is what these community-based testing events have been. So I'm not sure if that hopefully addresses your answer. It continues to expand. I think we're continuing to look at, we're, again, always looking at the possibility of false positives and false negatives. We know they exist with every test, but I think as we get into this reinfection discussion that we talked about before, that's also going to be an interesting part of the conversation as now we further go on, people who have already had COVID and then they have symptoms again and getting retested. So Dr. Hodder, I don't know if you or anybody else has anything to add.
Well, I would just say the advantages of antigen testing are, as Lisa said, it's faster and it's cheaper, but the false negative rate, and they're all a little bit different, but it's on the order, the false negative rate's about 20%. So, the issue is that if you have somebody who's symptomatic and you have a negative antigen test, it does not rule out that they have COVID. If you get a positive test, that rules it in. And I think that that's sort of an important way to look about it. But, testing has become, it's not just easy as doing a test that's positive or negative. We've talked about this before, even with the PCR test. that if you, the timing is important. And I think, you know, I think I showed a slide or so months ago that if you had, it was done in China, where if exposed individuals obviously were, you know, put in quarantine and they actually tested them every day. And for the first couple of days after exposure, you know, the PCR test was completely negative. It didn't start being positive until day 5. So, I mean, I think that, you know, that is, we're going to sort of continue to evolve how we look at testing. When's the best time to test? When can you really feel confident that a negative test is a negative test? And I think that that still is a book that's being written.
Yeah, and on that same note, I don't want to repeat myself in regards to false sense of security. I have seen more commonly people get a test and say, oh, I'm clear. Well, if you were exposed and you got tested, it's still, you need to quarantine for that set period of time. And we have seen more and more, I've heard from pediatricians that, you know, employers want their kids to be tested so that they can be quote unquote cleared to go back to work. Well, if it's a true exposure, even if they're negative in that moment, you still have to complete the recommended quarantine. And, you know, living on a college campus, working with medical students, I've heard many students tell me, oh, well, I got tested, I'm negative, I'm fine. So it's kind of like that. I'm no HIV expert, but with HIV, you know, there was a big push, like get tested, know that you're negative. Well, we're dealing with a respiratory illness here. So even though you're negative at one moment, you still could be positive in the future, particularly if you were exposed. And I see that a lot, where people trying to use testing as a way to shorten their quarantine, which unfortunately is not recommended. And we have seen some cases in that situation where, you know, someone should have continued to quarantine, didn't, and became positive afterwards.
Thank you both very much. The next question we got in through the chat was asking if you could speak about the different strains of SARS-CoV-2, and are there different strains, and is that by region?
Well, people are looking at that, but what you may be talking about is, and all viruses change. Coronavirus, by and large, changes less than something like influenza, or certainly less than HIV. But nonetheless, you know, the virus, as it sort of is replicating over and over and over again, it makes mistakes. And there has been a mutation that occurred after it left China in Europe. And I think we've talked about this before. The significance of that mutation is unclear. There is some evidence that suggests that that particular strain has higher avidity for the ACE2 receptors. It does not appear to be more pathogenic. Some people have said, well, this is why there's such a problem, you know, sort of in Europe and the US versus, you know, sort of China and East, you know, the Asian countries, which by and large, not exclusively, but have had better control. I think that remains to be proven.
Thank you very much. Dr. Costello, was there something you wanted to add as well? Okay, great. So the next chat we got in from Agnes was addressing the fact that there have been some cases of subclinical myocarditis in athletes and other young and middle-aged adults. So she was wondering if, is anyone screening for myocarditis in children who are asymptomatic or only have mild symptoms? And as a follow-up to that, she was wondering if there is evidence of myocarditis, planning to follow them to see if there are any long-term cardiac complications, such as cardiomyopathy as they become adults.
So I can start with this, and then Dr. Hodder, if you want to chime in. I think that we're still learning more. The AAP has put out guidance in regards to children, and you know, I think that we continue to look at this, particularly in athletes, as you mentioned, and there has been some evidence perhaps of myocarditis. I know that with MISC, or multi-system inflammatory syndrome in children, some of the cardiac manifestations we see in that are more than what's seen in Kawasaki disease. One of our pediatric cardiologists sent me kind of a diagram or algorithm, if you will, of what to do in patients who have a history of COVID-19 in regards to their participation. And I think people who are asymptomatic or they had mild symptoms, then there's not much further workup. Individuals who have had moderate symptoms and are older, like teenagers, and they do engage in higher competitive sports and physical activities. This kind of algorithm recommended an EKG. If it was normal, then you could clear them. If it's abnormal, then you would have them be seen by a pediatric cardiologist. And then I think individuals who obviously are symptomatic, they've had chest pain or they were hospitalized and have abnormal EKG or they have the MISC, then you would follow the typical myocarditis return to play guidelines where you would do EKG, echo, consider a Holter monitor, stress test, even a cardiac MRI. If there is that concern that you have for, a person that has myocarditis. So still going back to making or determining if they have symptoms of myocarditis. But I do believe there are individuals studying that, and I'll share that algorithm that I was sharing from one of our cardiologists with Mitra, that she could potentially share more. But I think it's still something that we're following and identifying, especially in individuals who had an elevation in troponins or laboratory evidence of some type of myocardial impact. Then certainly those individuals, I think, need to be studied long term. And there's been studies before that I know Dr. Marsh has mentioned where when they've looked at the actual myocardial tissue, there has been, they've found SARS-CoV-2 virus in that. So I think it's still something that we'll have to continue to look at. But from what I'm hearing from most individuals, you would only really screen for it if they were having symptoms. And so if they're having chest pain, or more severe symptoms, shortness of breath, of that nature.
Yeah, no, I agree. I think we talked a couple months ago about the German study that was a population, some of whom had been hospitalized, some hadn't, some were asymptomatic, and a considerable proportion had evidence of involvement, whether it be pericardial infusion or NMRs were done in some of those folks that showed myocardial involvement. And I think that, again, it's new what the optimal screening is, or, how to follow these folks. I think cardiologists are really working on that the world over. And I would anticipate over the next couple of months, we'll perhaps get, evidence-based guidance on that. Right now, it's very unclear, at least to my read.
Thank you both.
And I know, just to add on, the American College of Cardiology, they have a very robust website that they update periodically. From the beginning, they've been doing when there's been the discussion about ACE inhibitor use and, what you're seeing on echocardiogram. So I would refer you to them as well, because they've kept a pretty good running list of different studies, in particular to cardiology issues related with COVID.
Absolutely. So Dee chatted in asking if you noticed any difference in enterovirus transmission this fall in the setting of mask wearing, hand washing, increased social distancing, etc.
I do not know the answer to that. I mean, I'll just be completely honest. I don't know if Lisa does, but I wouldn't even want to hazard a guess.
I don't know in specific to enterovirus. I know that Australia reported a lower incidence of influenza. Now, whether that was just going to be a lower influenza season, but what we have seen in the Southern Hemisphere when it comes to influenza, it was a milder season than recent past, and the thoughts are still out as the cause of that. in regards to, is it everyone just being more following the guidelines for COVID and that's preventing spread of other illnesses? I know a few years ago with our SARS outbreak, when they instituted hand washing in schools, they actually had lower absenteeism than they had prior years because they were also preventing transmission of diarrheal disease and other type of diseases. So I think time is going to tell in regards to how much other disease transmission we see, but I can't speak specifically to enterovirus, but I can say that at least in the Southern Hemisphere, they did see not as much flu activity. And again, there could be potential multiple reasons for that, but one thought is the mask wearing, hand washing, physically distancing may have played a role in reducing transmission of that disease, as well as, influenza vaccine. I mean, hopefully everyone on here has gotten their flu shot, but just anecdotally, we're seeing a pretty good uptake of flu vaccine in areas, whether it's just people are coming out early to get them, or we actually are seeing more individuals be motivated to get a flu vaccine. And so that's a positive trend early right now, but hopefully that will be sustained. So we're unsure if just everybody's coming that would usually get their flu shot and they're getting immunized really early, and then that number will trickle off, or are we going to stay at higher levels of influenza vaccine this season, which also may help reduce numbers of influenza and hopefully also reduce severe illness from influenza.
Thank you very much. And I remember from last session, you mentioned flu before boo. So we'll keep that in mind as well. So we got another chat asking or addressing the fact that a lot of people are going through pandemic fatigue and pandemic anger, causing increased rates of viral transmission for both COVID-19, flu, and other viral pathogens. So they were just wondering if you have several of your top recommendations you would give to parents and young adults to deal with fighting the pandemic fatigues and anger.
Well, I can, I guess, start with this one. And if any of I also welcome Samantha, Dr. Miam, your input, or any other psychiatrists or psychologists that are on. I think that we know that, there's stages of pandemic response, just like in a stage of grief, and there certainly gets to be fatigue and denial. And so I think many of the strategies that I'm still recommending for children are, at least when it comes to the pediatric population, having a discussion with them and asking them to open up about their feeling and normalizing that it's okay to have some of the feelings that they're having. Try to get to the heart of the issue why. And sometimes parents, they've allowed their children to engage in more screen time, whether it's playing video games, and they have found that that's actually not been a good thing because it's led to further anxiety. So then cutting that out and doing activities like getting outside more, engaging in physical activity. The AAP has put out many different suggestions on things you can do to still engage in physical activity outside or different activities, but we are hearing this across the board because, now what I'm hearing is, well, we've gone on all the hikes that we can go on, and so now they want something else to do. So I think just, again, providing a space for children to talk about how they feel, to say that it's okay to feel that way, and provide reassurance that they have support. And if they do have more severe symptoms, then getting them additional help and interventions to work through those and making the home a safer place. And then I think, particularly when it comes to children, they model a lot off of parents. So if the adults around them are anxious or worried about what's going on, the children are going to feed off of that. And so I think it can be important to also know what the adults or the guardians around them are consuming to then, maybe limit that. So, or to not discuss it around the children if their children are having more impact. So that's the children piece. Dr. Hodder kind of hit on before a little bit and could go. I do think that we're seeing fatigue across the board. People don't want to wear their masks anymore. Hopefully everyone has always wanted to wash their hands, but I've been very enlightened throughout this that, many people have learned how to better wash their hands, but hopefully that's something that's going to persist forever. But the physical distancing, the not gathering, as Dr. Hodder mentioned, we are seeing smaller gatherings now lead to spread. And so it is a real problem that I think we're trying to address, but it continues to be hard. People, they get sick of hearing the same thing over and over again. But I think continuing that optimism that, a vaccine is hopefully on the horizon. But I think when even we do have a vaccine, we're still going to need to be wearing our masks and washing hands and maintaining physical distance until we can have more of a mass distribution of that vaccine. So I think that's going to be important in the messaging. But Dr. Hodder, or I would welcome input from anybody else because I'm not a psychiatrist or a psychologist.
This is Samantha again. I think that you are spot on, absolutely. And I think, unfortunately, all of our COVID talk and mask wearing talk is now wrapped up in our politics talk. And we've got the election coming up. And so I will admit that I am on Facebook more than I should be. And that's all I'm seeing anymore is jokes about wearing masks or jokes about politicians, and it's all negative pretty much. So I think that limiting our time that we're on social media is very important. Learning how to talk about it more positively. And what I would love to see, if anybody's doing this, please let me know. But exactly what we're doing right now, except for communities, just a place where we can see people, speak to their faces, and have that connection at more as a support system. Because this, for me, is awesome to be able to hear other people saying the same things that I know and have been saying is very validating for me. So I think that our communities could benefit from that greatly. So I don't know if it's possible or who could do it, but we need to have this available for our communities.
Yeah, I kind of, the politicization is unfortunate because this is about saving lives. And you've seen, as much as I said about models forecasting the future are bunk, I think the models for, really predicting what could have been saved, the souls that could have been saved are not exactly accurate, but pretty close. And so, it's really about preventing people from dying who don't have to die. I mean, once you die, that's it. So my way of thinking about this, and I learned this sort of in my front row seat at the AIDS epidemic. I was an intern in San Francisco in 1980. And there, in that epidemic, we had no idea. We couldn't even test for the virus for 3 years. We had a test with this one very quickly. We had vaccine candidates in the United States in animals last January. So this is much different. And I do not think that this is going to go on forever. I think there will be a breakthrough. And so it's really right now about having, sort of power over that virus, doing what you can do to not get infected. The breakthrough will come. Lisa's absolutely right. I think as this vaccine rolls out, there are going to be people that don't respond to it. You got to have, a lot of people immunized, at least 70%. We won't even go into herd immunity on that one. But so we're going to have to continue these behaviors. It's not like the vaccine's going to come out on Tuesday and Wednesday, everybody can quit wearing their mask. But nonetheless, I do think the end of this sort of draconian, sort of stuff we have to do behavior-wise is not forever. And when you realize that it's not forever, for me, I mean, maybe I'm just weird, I think it's a lot easier to deal with.
Absolutely. I'm the same way, Dr. Hodder, for sure. And thank you, Samantha, for your input as well. We really appreciate it. So we got a chat in from Dr. Leonard asking if we have any studies demonstrating the incidence of myocarditis in typical viral illnesses, and is COVID really much more?
I don't have the numbers off the top of my head. I think that, again, unfortunately, a lot of this is time will tell because we're still very much dealing with COVID, and we have to, I was on a call yesterday with the AAP. I mean, we are seeing, higher numbers than we were in the beginning of this in regards to children getting infected. Children still are about 10%. That's 18 years and younger of all COVID cases, but it's kind of plateaued. And so, I think from across the board, whether it's children or adults, we're going to have those ongoing studies to determine, is it much more than what it is at baseline, or, like we see with Coxsackie virus that tends to lead more to myocarditis, is that, or is this just typical of what we would of, in this day and age, we didn't have social media back with the HIV. Like now people are seeing science unfold real time. Like I don't think I've ever seen so many media releases of a vaccine because of an adverse reaction, where now I get a text alert from CNN that, and every other, news agency that a clinical trial has been stopped because of this. So I just think we're so much more in tune and want the answers real time. But at the end of the day, it takes time to do these studies. It takes time to follow the data. And so we may have that answer. I'm not aware of it thus far. I don't know if Dr. Hodder or anybody else on the line has any other specific information, but I don't know any specific.
Dr. Hodder, you're muted. Thank you.
Sorry about that. The German study that we talked about, which was only 100 folks, some of whom had been hospitalized, some not, 70% had elevated troponins, and, roughly that percentage had evidence of some involvement, whether it's just pericardial effusion or myocarditis. The percentage that go on, we don't know. If you look at CMV, for example, that could be associated with a myocarditis. Of those, 10% go on to a chronic cardiomyopathy, but this is a completely different virus. What I would say though is myocardial involvement with viral infections is not new. It happens with influenza, it happens with CMV, Lisa mentioned it happened with Coxsackie. And I don't think that we have taken other viruses and looked as quickly and as carefully as we are with this one. So I would suggest, you really have sort of the understanding where we might not have looked that carefully, for example, with influenza, but clearly there were cases of myocarditis with other viruses. And I think we'll have a really good idea, as Lisa mentioned, a lot of folks are really
Thank you very much. So we have about 6 to 7 minutes left. So I will ask one more question that we got in, and if we have some time, we'll play it by ear and maybe ask another one. So the next question we got in was asking, are asymptomatic patients less contagious, and are pre-symptomatic people less contagious as well?
That is a great question. And I think, like with most things, we don't know the relative risks, but it's very clear that people who are asymptomatic can transmit virus. There has been one study that I know of, and again, you can imagine the issue with looking at asymptomatic people and then figuring out to whom they transmitted the virus. It's really difficult. But there was one study that suggested that actually asymptomatic folks, though they clearly could transmit, did so less frequently than pre-symptomatic folks. You got to be really careful. Asymptomatic means you don't have symptoms and you don't develop them. Pre-symptomatic means that in the first couple of days after infection, you don't have symptoms, and then you develop them. And what they have seen is really that folks, particularly right before they get the symptoms that day or the day before, have what they've correlated with the highest burden of virus, and those folks have been more likely to transmit. Now, on the other hand, I would also say that if you're really feeling, really bad and home and so forth, of course you're not going to transmit because you aren't going out of your bedroom. So, there's a little bit of, I think, confounding that may or may not have been sorted out. But I think the bottom line is, pre-symptomatic and asymptomatic people can transmit virus. Perhaps pre-symptomatic transmit more often. And there has been some evidence that particularly right before you develop symptoms or early on, you're more likely to be infectious than later on.
I think that's well articulated. The only thing I would add, for a little bit of a pun, hindsight is 2020. I've talked to some public health individuals who have contracted COVID, and they have said, in retrospect, that's what makes this disease so challenging, is that the symptoms were probably so subtle that they wouldn't even expect it to be related to COVID, and then they've already spread it. And so, I think that's the challenge that we've experienced in regard to some individuals having such subtle symptoms, so that pre-symptomatic phase. And if they were spreading before that, and then getting the test back quickly, identifying their contacts, it makes it challenging to really reduce that transmission versus, like what Dr. Hodder said, if you're having pretty severe symptoms, you're likely not going many places. But, I think we still continue to learn more about the spread and how much, what symptoms they're really. I continue to be surprised. To me, the loss of taste and smell continues to be the one that seems to at least really trigger it apart. I don't know, Dr. Hodder, that's what, particularly maybe in the milder or those asymptomatic folks, that's what I then hear. They said, I lost my smell and taste, and that's when I decided to go get tested for COVID. They maybe have been stuffed up a little bit, but then it was just that was their trigger. And so that's, at least in my, I guess that's been my impression over the past few months. That symptom at least sticks out to me as being one of the things that sets COVID apart. And I don't know, Dr. Hodder, if you have any comments on that, but that's just what I have found over time to be more and more of that defining symptom that really does tend to say, oh, okay, this maybe I should go get tested.
Yeah, no, I think you're exactly right. And there's been literature to suggest that though, relatively minor proportion of individuals who are infected will develop a loss of taste or smell. Actually, that is pretty specific as it goes for COVID. So I agree completely.
Thank you both very much. So we have a few minutes left. I did want to leave some time for the polling questions at the end of the session here. So I think we will end the session here. I wanted to thank you all so much for joining and participating and being so engaging. And a lot of great resources coming in through the chat as well, which as always, I'll include in the recap email. And thank you very much, as always, Dr. Hodder and Dr. Costello for answering all the questions and being so great. So thank you all so much for being so enthusiastic and everything. So a couple housekeeping announcements. Our next session will be on November 5th, and we are going into 2021 with the COVID echo sessions. So keep an eye out for any reminders that come through. And we will see you all next time. Thank you so much. I will launch the poll. Anytime you guys are completed with the poll, just feel free to log off. Thank you so much.